This is Dr. Yosafit. I come with previous UC exam question with their answer for public health officer. If you get some important pointers from this video, please like, share, and subscribe my YouTube channel in order to get next video easily. Question number 1. The patient is diagnosed with type 2 diabetes mellitus. He is advised exercise and dietary modification. He is referred to an ophthalmologist and appropriately screened for diabetic retinopathy. What is the most sensitive test to screen for nephropathy in this patient? A. Creatinine clearance. B. Dipstick testing of urine for protein. C. Random urine for microalbumin and creatinine ratio. D. Oral glucose tolerance test. So which is the answer? So pause your video and please try to answer or to pick one of the choice. So in order to start from the choice A, creatinine clearance is used for estimation of glomerular filtration rate, which you call this GFR. So GFR is used to detect if there is any problem with the function of kidney and detects if there is any chronic kidney injury or acute kidney injury. So creatinine clearance is used to detect if there is any problem with the function of kidney. So it's not that much important to screen for nephropathy. Choice B, dipstick testing of urine for protein. So this may be somewhat helpful, but if there is very low proteinuria, that what you call it microalbuminuria, this dipstick testing may not detect such a low level of protein. So this is not an answer. When you come to choice C, random or spot urine for microalbumin to creatinine ratio. And definitely this is an answer. This is an answer. This is an answer. So choice C is an appropriate and definite answer for this patient. So D, oral glucose tolerance test. Oral glucose tolerance test, whether it is low or high, is not helpful to screen for nephropathy. So the answer is C. So the patient, the question narrates about the diabetic retinopathy, and then you are asked about for the screening of nephropathy, because that individual who have diabetes nephropathy commonly have diabetic retinopathy. So diabetic nephropathy is by far the most common glomerular disease in developed countries, and the incidence of nephropathy is directly proportional to the duration of diabetes, and it's normally appear as microalbuminuria after at least 10 years of type 1 or type 2 DM. So diabetic nephropathy appear as microalbuminuria. So microalbuminuria, which is 50 to 300 microgram per 24 hour, is detected using a spot or random urine albumin to creatinine ratio, not the routine urine analysis, which is insensitive to low degree of protein urea. So our answer C is correct. So screening for albumin. When do screen for albuminuria? One is 5 years after onset of type 1 DM, and the second at the time of diagnosis of type 2 DM. So for the second, as you know, when you diagnose type 2 DM, you suspect that there is micro or macrovascular complication. So you will screen for the different complication, one of which is for the diabetic nephropathy. And the third screening for albumin urea is that during pregnancy. So during pregnancy, you can screen for albumin urea. So the second question, a 50-year-old man comes to physician for routine checkup and he has no present complaint. He has DM type 2 and stable angina, gout, and he takes glyburide and atenolol. He smokes 2 packs a day and occasionally consumes alcohol. His father had an early MI. His brother has DM. His blood pressure is 140 by 90 millimeter mercury, and his heart rate is 65 beats per minute. Physical examination show no abnormalities. There is a concern about end organ damage in this patient due to diabetes mellitus. In which of the following is the earliest renal abnormality to be present in this patient? A. Nodular sclerosis. B. Glomerular basement membrane thickening. C. Mesangial expansion. D. Glomerular hyperfiltration. So this patient is diabetic. So in order to answer such question, you need to know the natural history of diabetes nephropathy. So let us discuss natural history of diabetes nephropathy. So I put here the column. I put here the common years after onset of DM, renal change and change in GFR in year like in the first year of onset of DM, renal change become like glomerular hyperperfusion and also renal hypertrophy occur. So when we come to change in GFR after first year onset of diabetes mellitus, the GFR will become increased like a compensatory mechanism. So as you know, there is here the work of the kidney become increased because there is renal hypertrophy and also the glomerular there is glomerular hyperperfusion. So these two will increase the GFR. So within the first year of onset of DM, this renal change will ensue and the GFR will increase. So within first to 5 years after onset of DM, there is thickening of glomerular basement membrane, glomerular hypertrophy, and mesangial volume expansion, and the GFR returns to normal. So after 5 to 10 years after onset of diabetes mellitus, 40% of individuals began to excrete small amount of albumin in the urine, which we call it microalbumin urea. After 10 years, this microalbumin urea progressed to macroalbumin urea, which is a massive protein urea. So during that time, there is steady decline in the GFR, and in 50% of individuals reach end-stage renal disease in 5 to 10 years. So back to the question. So from this discussion, the earliest in this the earliest renal abnormality. This patient is diabetic patient. So what is the earliest renal abnormality to present in this patient? So the answer become glomerular hyperfiltration, which is occur at the first year after onset of diabetes mellitus. So mesangial expansion, glomerular basement membrane thickening will occur within the 1 up to 5 years after onset of diabetes mellitus, and this nodular sclerosis or which tell us the scarring will become very late stage, like when we consider CKD. So the answer is D, which is glomerular hyperfiltration, which become the earliest renal abnormality to be present in this patient. So the third question, a 35-year-old African American man comes to the physician complaining of 2 weeks of abdominal distension. He has been in drug rehabilitation program for 2 years due to prior heroin abuse. recent viral hepatitis HIV profile were negative. His temperature is this 37.1, blood pressure 145 by 82 millimeter mercury, pulse is 80 beats per minute, and respiration 14 breaths per minute. The patient is obese with body mass index of around 14. The examination show periorbital edema, ascites, and grade 2 pitting edema in both legs up to the knee. Breath sound are decreased at the right lung base. 24-hour urine shows protein excretion of 7.5 gram, which of the following is most likely diagnosis? A. Focal segmental glomerulosclerosis. B. Diabetic nephropathy. C. Membranous nephropathy. D. Minimal change disease. Let us see what this patient had. This patient has a disease state called nephrotic syndrome. Nephrotic syndrome, not nephritic, it is nephrotic syndrome. Nephrotic syndrome. Why would we say nephrotic syndrome? This patient have nephrotic syndrome because the patient have greater than 3.5 gram of proteinuria, gram of protein excretion in the 24 hour, and this range is called nephrotic range of proteinuria. So the patient have edema, hypertension. You know this. The patient have edematous. The patient have edematous, and the patient is hypertensive. So along with this is nephrotic syndrome. This is nephrotic syndrome. So when you come to the choice A, this is focal segmental glomerulosclerosis. Do you think this will be the answer? Yes. This all can cause nephrotic syndrome or nephrotic range proteinuria. In order to differentiate those cause of glomerular disease, these are the one of the primary glomerular disease. So all the choice will cause nephrotic range of proteinuria. When you come to focal segmental sclerosis, this is the most common cause of nephrotic syndrome in developed country, and it is associated with heroin abuse, HIV, and morbid obesity. So definitely this is an answer, because in addition to causing nephrotic syndrome, the secondary cause of this focal segmental glomerulosclerosis is that they is associated with heroin use and morbid obesity, and also hypertension. So definitely A is an answer. Diabetic nephropathy, this patient, even if something is a risk factor for, but we don't have any history clue which tell us diabetic nephropathy is the second, membranous nephropathy, and the D is minimal change. This is minimal change disease. Minimal change is the most common cause of nephrotic syndrome in pediatrics group. The most common cause of this is commonly cause nephrotic syndrome in pediatrics group. So this is common glomerular disease. So as we define glomerular disease as a nephritic and nephrotic syndrome, especially based on the proteinuria. Nephrotic syndrome is greater than 3.5 gram per 24 hour, and nephritic range is less than that level. So, and also nephritic syndrome is associated with hematuria as well, and more of nephrotic syndrome is associated with hypertension, edema, and also the nephrotic range proteinuria. So this is the most common cause of membranous glomerulonephritis, focal segmental glomerulosclerosis, and membranoproliferative glomerulonephritis, as well as minimal gene disease are most common cause of nephrotic yes, from primary one. So focal segmental glomerulosclerosis, the most common cause of nephrotic syndrome in adults in USA. Secondary forms are seen with HIV nephropathy, the use of heroin, as well as morbid obesity, possibly due to hyperfiltration. So membranous glomerulopathy, most are idiopathic or primary. Secondary forms are associated with SLE, cancer such as lymphoma, breast cancer, infections such as endocarditis or chronic hepatitis B or C, and drug like NSAIDs, penicillamine, and gold salts. So there is no in our choice, there is no risk factor like SLE and malignancy in order to choose the C. So the answer is A. So the last one, patient number 4, a 57 years old woman is admitted to ICU after being involved in high motor vehicle accident. She was hypotensive at the skin and received 7 liters of fluid, which included crystalloid, blood, and fresh frozen plasma. She apparently had significant external blood loss from multiple fracture and skin loss. She undergoes surgery, after which she is transferred to ICU and received continuous IV fluid and vasopressor. Her laboratory study after 24 hours after the accident shows the following: hemoglobin, she's anemic, WBC, leukocytosis, and BN34, and serum creatinine is elevated 2.2 milligram per deciliter, which is the following is the most likely microscopic finding on urine analysis: A, broad cast; B, muddy brown cast; C, RBC cast; D, WBC cast. So this patient have AKI, acute kidney injury. So that is defined with BN creatinine elevation. So as you know, acute kidney injury is rapid decline in GF, glomerular filtration, as seen in rising BN and creatinine. So acute kidney injury is defined as pre-renal AKI, post-renal AKI, and intrarenal AKI. So pre-renal means decreased perfusion of the kidney, like CHF renal artery stenosis, especially bilateral renal artery stenosis, and volume depletion. The kidney itself is healthy. When it comes to the post-renal, indicate renal obstruction, causing decreased drainage from the kidney and decreased forward flow of urine, like stones, prostatism, pelvic malignancy. And for prostatism, the most common cause of prostatism is BPH, benign prostatic hyperplasia, which causes bladder outlet obstruction and post-renal renal AKI or acute kidney injury. The kidney itself is healthy in post-renal AKI. Intrarenal AKI means a reduction in GFR due to a renal tubular or interstitial glomerular disease. Example: glomerulonephritis, acute tubular necrosis, acute interstitial nephritis, and the kidney is defective here. So, which type of acute kidney injury does our patient have? And at the same time, answer the question. So, this patient has intrarenal AKI, intrarenal AKI, intrarenal AKI. Why do we say intrarenal AKI for this patient? One is that the patient, one of the clues to distinguish intrarenal AKI and postrenal AKI from the um, pre-renal AKI or renal azotemia is that blood urea blood urea to nitrogen. Blood urea nitrogen to creatinine ratio is greater than 20 ratio 1 in pre-renal AKI. So in post-renal and intra-renal AKI, the ratio become less than 10 ratio 1. So this patient have BUN 34 in creatinine 2.4, which is around here. So it is intrarenal or post-renal AKI. So there is no obstruction with which causes bladder outlet obstruction. So this patient have intrarenal AKI, and from that intrarenal AKI, this patient have acute tubular necrosis because there is hypotension for for acute tubular necrosis to occur. There must be hypotension and also ischemia. I mean, hypoperfusion to the kidney, and one may be caused by ischemia or toxins. So the patient have hypoperfusion, one of which is due to excessive blood loss and also hypotension. So this patient has acute tubular necrosis due to hypoperfusion of kidney. So if the patient has this acute tubular necrosis and you send urinalysis, which of these casts do you see in acute tubular necrosis? This is all about the question. In acute tubular necrosis, you see muddy brown or granular or muddy or dirty brown cast or granular cast. So when you come to the choice C, RBC cast, you only see you only seen this RBC cast in glomerulonephritis. If you see RBC cast, it is glomerulonephritis associated with nephritic syndrome. So there is no history or laboratory investigation which suggests this nephritic syndrome or glomerulonephritis. So WBC cast can be seen in UTI, interstitial nephritis, or pyelonephritis. So the answer is B. So acute tubular necrosis, this is what we discussed. So this is due to tubular damage and necrosis leading to reduced solid clearance, AKI, and diminished electrolyte and water regulation, causing include ischemia and hypoperfusion of the kidney and shock. And so this patient may have shock. So tubular toxins like drugs like aminoglycoside can cause acute tubular necrosis. And this is very important slide telling about the castes. So here we do have hyaline cast, which is by the way the most common cast seen in urinalysis. So hyaline cast is seen in dehydration. In dehydration, these casts develop as an accumulation of normal amount of tubular protein. They do not necessarily mean disease. So normally you can see hyaline casts. Red cell cast, as discussed before, it is seen in glomerulonephritis. So broad waxy castus, it is seen in chronic renal failure, and granular, which is our answer, also called dirty or muddy, are associated with acute tubular necrosis and represent accumulated epithelial cell. And finally, this white cell cast seen in pyelonephritis and interstitial nephritis. Thank you for watching. Please subscribe and like and also comment in our video. So thank you very much. Thank you.